I'm Dr. Roberto Victor Ia, and I'm going to discuss Nesidioblastosis, which is a frequently overlooked but common disorder of blood glucose. The worldwide problem we are having in diagnosing and treating diabetes relates back to the fundamentally incorrect paradigm which is promulgated by the American Diabetes Association. In their position statement printed in Diabetes Care, January 2012, they state, and I quote, "Hyperglycemia defines diabetes, and glycemic control is fundamental to the management of diabetes." This is incorrect because hyperglycemia is a sign because of the Somogyi phenomenon described in 1938 by Michael Somogyi, that the blood sugar may fall and then rapidly rise above the upper limit of normal, which is 140 milligrams per cent. So there are many conditions where one sees hyperglycemia, but the fundamental problem is not high blood sugar. So hyperglycemia cannot be used to define this entire class of ailments. And the one we're going to discuss today is Nesidioblastosis. More broadly defined, it's endogenous hyperinsulinism. So it's the most common type of hyperinsulinism. The beta cells are overproducing, in a random fashion, insulin. The diagram depicts the increased mortality both with elevated blood sugar out of the normal homeostatic range of 70 to 140 on the high side, and notice that there is increased mortality when the blood sugar is low. This is the study of white-collar civil servants and teachers from Taiwan, published in Diabetes Care 2005. I think this reflects the mortality associated with the hypoglycemic syndromes, including nesidioblastosis and hypothalamic hypoglycemia. This is a photo of Dr. Michael Somogyi, a chemical engineer, who first described the phenomenon in which the blood sugar rebounds after being low if you use excessive hypoglycemic agent, whether it be an oral agent or insulin. This is the February 1959 American Journal of Medicine paper in which Dr. Somogyi mentions endogenous hyperinsulinism, which can be insulinoma or nesidioblastosis, and the hyperinsulinism resulting from excessive administration of insulin. Both will provoke a Somogyi response, low sugar followed by high sugar. This is a slide from the Simlin slide set showing that although the hemoglobin A1C might be in an acceptable range, the patient may be experiencing very wide excursions of blood sugar, very low blood sugars followed by Somogyi rebounds. The review of the medical literature shows that reports of hypoglycemia began to appear in the early 1930s. This was a mystery until George Friedrich Laidlaw, a pathologist, described nesidioblastosis. What has confused the medical community is the lack of understanding of the rapidity of the Somogyi rebound phenomenon after hypoglycemia. Our work has shown that this rebound may occur within 60 seconds or less. Insulin resistance was first described in 1932 without any evidence whatsoever. With the advent of continuous glucose monitoring and more sophisticated equipment, it's become clear, at least to me, that the human body doesn't one day become resistant to its own insulin. There is no model or precedent in biology for this. The dawn phenomenon was a syndrome created because a rise in morning blood sugar was noted, but with the advent of the continuous glucose monitor, we now know that this is simply a Somogy rebound following nocturnal hypoglycemia. This patient was 63 years old in 2009 when I first saw him. His chief complaint was dizziness. He was diagnosed with type 2 diabetes 5 years before this. He was given glucophage 500 milligrams twice daily, Amaryl 4 milligrams once daily, Actos 45 milligrams daily, Humalog 3 times daily on a sliding scale, and Lantus insulin 40 units at night. I changed his medical regimen to the following: Actos 45 milligrams daily, Lantus 20 units at night, and Januvia 100 milligrams daily. He continued to complain of fatigue and occasional shakiness, but he was improved. Note the wide excursions of blood sugar on his home meter. This is a Dexcom 7 continuous glucose meter recording showing marked hypoglycemia and hyperglycemia. His insulin was stopped, and this study was done, which is a 4-hour modified glucose tolerance test with insulin and glucagon values. Note that he had very high insulin values, both fasting at 1 hour, 2 hours, and 3 hours. His March 2012 non-contrast brain MRI showed a single white matter lesion on the left. So the patient had probable Nesidioblastosis. The elevation of any insulin value doesn't reflect the severity of disease. It can be a mild elevation or a very marked elevation. And the release of insulin from the nesidioblastotic pancreas is random, not only in timing, but random in the amount of insulin released. This 47-year-old female presented with impaired concentration, impaired short-term memory, blurring or double vision, weakness of limb muscles for about 20 years, muscle twitching, anxiety, labile hypertension, episodic flushing and diaphoresis, difficulty falling asleep. She would wake in the middle of the night, agitated. She had episodes of irritability and emotional outbursts. She experienced episodes of tachycardia and irregular heart rhythm, and she had difficulty with her balance. Note the wide excursions of blood sugar from her home glucose meter. These wide excursions were again seen on the continuous glucose meter recording with very low values and very high values. The GTTID study of 11/16/2010 showed elevation of insulin at 3 hours and 3 hypoglycemic sugar values. The non-contrast brain MRI showed multiple white matter lesions. Robert S. was an 89-year-old Caucasian male. His chief complaint was difficulty with balance for 10 years. He had impaired concentration, impaired short-term memory, He said he had a couple of TIAs with loss of strength in his limbs. He was depressed. He had periods of tachycardia. He had paresthesias of his toes in both feet. His GTTID study showed hyperinsulinism at 3 hours, and as you see, both low and high blood sugars. Once again, the continuous glucose meter study showed both hypoglycemia and hyperglycemia. This is the example table I use of the insulin normal ranges and glucagon normal ranges, which are timed, are obtained from the laboratories. We have fixed the normal homeostatic range at 70 to 140 based on published literature in this field. Here is a list of the items that you need to diagnose a disorder of blood sugar. If available, you should do a continuous glucose monitoring to detect mainly hypoglycemic syndromes. One of the earliest screening tests you should use is a C-peptide, which is an index to insulin production. This 38-year-old gentleman was seen by me for the first time in 2009. He had extreme weakness of his legs and used a wheelchair. It turned out that he had Nesidioblastosis, and within 4 months of treatment was able to walk. Again, note the wide excursions, hypoglycemia to hyperglycemia in this patient. Here we were fortunate enough to catch the hyperinsulinism and both hypoglycemia and hyperglycemia on the GTTID test. Note that the patient had been under treatment for multiple sclerosis for several years without improvement. The GTTID test was repeated, again showing the hyperinsulinism, but not showing the hypoglycemia. Recall, this is a random process with rapid oscillations in blood sugar, so most of the time you will not see hypoglycemia, and so it's best to rely on the insulin level for the diagnosis. Sometimes the glucagon will be elevated, reflecting prior hypoglycemia. This is a computer software readout of the number of minutes spent in neuroglycopenia, 30 minutes, and the low point, which was 47 milligrams percent, and the number of minutes in mild hypoglycemia, which was 25. This is the second recording on the same patient done in November of 2011. This is the third Dexcom continuous glucose monitor analysis done in March of 2012, showing elimination of the mild hypoglycemia and the neuroglycopenia with treatment. Same patient, continuous glucose meter recording. Hypoglycemias have apparently been eliminated, but they are still there, just reduced in number. We know this because the patient is still having Somogy rebounds. This is his non-contrast brain MRI showing white matter lesions. This is a 58-year-old male who complained of daily recurrent weakness. He had, prior to seeing me, documented episodes of hypoglycemia. He had depression and uncontrolled anger. and was under treatment for this. This is his home glucose recording. Again, note hypoglycemia and hyperglycemia, wide excursions of glucose. January 2012, continuous glucose recording showing both hypoglycemia and hyperglycemia. Remember, each dot is a 5-minute average of 1-minute readings. Still, the hypoglycemia is readily apparent. This is the computer analysis of the patient's Dexcom 7 continuous glucose meter study showing neuroglycopenia and hypoglycemia, which is mild between 70 and 55. January 2010, same patient. No glucagon studies were being done by me then, but you can see that the insulin value at a half an hour was 225.9, very high, but he had low readings at 1 and 2 hours. Notice on the glucose, the patient had recordings which showed low sugar at 1 hour, but at a half an hour I had elevated blood sugar. This is a repeat study later in the year on patient GP. Patient GP, non-contrast MRI, single small white matter lesion on the right. 36-year-old female who had multiple episodes of syncope, and when taken to the emergency room multiple times, nothing was found, and the patient was told she was hysterical. She began experiencing memory loss, short and long term. Home glucometer showing wide excursions, hypoglycemia and hyperglycemia. A suboptimal first Dexcom study, November of 2012, but hypoglycemia demonstrated. Dexcom computer analysis showing time spent in neuroglycopenia and mild hypoglycemia over a period of 3 days and 18 hours. Michelle T's GTTID, June of 2009, showing the high insulin levels. Repeat GTTID, same patient, 223/10. High insulins are gone, but the patient now has random low blood sugars, characteristic of hypothalamic hypoglycemia. So the patient has moved from Nesidioblastosis to hypothalamic hypoglycemia, and we've seen this several times. Linda F., 61-year-old married female, chief complaint, vacillating blood sugars. She has tremors, she drops things, she's irritable. Sometimes she feels as though she's not really tuned in. No loss of consciousness. Year before, she fell at our front door and broke her ankle. Although less striking than the previous cases, there is still wide variation in the home blood glucose recording. This is her GTTID with elevated insulins and high sugars seen. Post-treatment, February 2012, no high insulins, but she has 2 entries which show low insulins. Glucose is stable and glucagons are normal. A continuous glucose monitor report showing the rebound Simoji episodes, but no hypoglycemia. This is a computer analysis of the previous Dexcom 7 continuous glucose meter study with the hyperglycemia showing, but no hypoglycemia. Linda F., non-contrast brain MRI, note the multiple white matter lesions of recurrent hypoglycemia. Richard S., 73-year-old married male, previous episodes of hypoglycemia, sudden loss of awareness and ability to respond without clear-cut loss of consciousness, impairment of short and long-term memory, and episodic tachycardia. Richard S., home glucose recording. Again, note the vacillations in sugar. Richard S., March 2010, low insulin at 1 hour, but a high insulin at 4 hours, 2 high blood sugars. Richard S., Dexcom 7, continuous glucose monitoring report. Note the hypoglycemia and hyperglycemia. Richard S., first Dexcom analysis, showing he had 135 minutes of neuroglycopenia in 3 days and 19 hours. Richard S., second GTTID, no hyperinsulinism, 0 in 1 hour, low insulins, normal blood sugars, normal glucagons. This is post-treatment. Second Dexcom 7 CGM, no hypoglycemia, but hypoglycemia is still occurring, as we can tell by the presence of Somogy rebounds. Richard S., second Dexcom analysis, March 26, 2012. Note the absence of neuroglycopenia and hypoglycemia. This is much improved. Richard S., non-contrast brain MRI showing white matter lesions. The next case is a little difficult. I call it a curveball. Richard G. has a low C-peptide, was treated with metformin initially and started on Humalog and then Lantus. He has episodes of low blood sugar and mild renal insufficiency. Other lab data are on the slide. This is a list of his medications for his, quotes, diabetes, close quotes, Humalog, total of 20 units a day, Lantus, 80 units at night, Actos metformin, and Byetta twice daily. This is a GTT ID on patient Richard G. Note that all the insulin values are very high. He stopped his insulin only the morning of the test. He was on Levemir. Richard G. line graph of home blood sugar readings. Richard G.'s non-contrast brain MRI from 2010 showing the shunt tract and multiple hypoglycemic infarcts on both sides. Richard G.'s Dexcom 7 CGM graph. Richard G.'s Dexcom report analysis. 45-year-old female presenting with severe uncontrollable hypertension as high as 214/118. She'd seen other doctors and been tried on a number of antihypertensive agents. She has fatigue, weight gain, diaphoresis, episodes of anxiety, and what she calls painless migraines and sparkles in her visual field. On one occasion, she had peripheral visual loss, which passed in 20 minutes. Line graph from home glucose meter. As you can see, her 2009 GTTID study was very abnormal. (2011) Dexcom CGM showing the hypoglycemia and occasional hyperglycemia. Computer analysis of that first Dexcom study. Second Dexcom study, November 2011. Analysis of the Dexcom study, November 2011. Kaylin L., 55-year-old female, impaired concentration, impaired short-term memory, an episode of what was termed Guillain-Barré syndrome. She snacked between meals. She was gaining weight. She had depression and anxiety. She had flushing and diaphoresis, difficulty falling asleep. She had dizziness and lightheadedness. Home glucose meter graph. Kaylin L. GTT-IDG study showing high insulins. Low blood sugars documented on Dexcom 7 CGM. A computer analysis of the Dexcom 7 CGM showing mild hypoglycemia. Kaylin L. non-contrast brain MRI showing white matter lesions. Nesidioblastosis in a young woman associated with a large area of cerebral infarction, but reversible neurologic deficits. This 35-year-old female had two episodes. The second was more profound. During the first, she was dizzy and lightheaded and, as she says, felt woozy. On the second occasion, she was at work and was sitting down and felt severe head pain and was unable to focus her thoughts. She got up and stumbled into a wall. Home glucose meter graphing. 4-hour study showing hyperinsulinism and hypoglycemia. Her very dramatic non-contrast brain MRI showing a single white matter lesion below a very large area of infarction. Abnormal Dexcom 7 study. Computer analysis of the abnormal Dexcom study showing neuroglycopenia, that is blood sugars below 55, total 40 minutes in 3 days and 16 hours. I want to remind you that the continuous glucose meters in their current states miss a lot of significant hypoglycemia. I would say perhaps 20-25% of the time. The 5-minute averaging that's done in the meter will miss the brief periods of hypoglycemia. Sometimes 2 or 3 studies have to be done to detect the clinically significant hypoglycemia. Robert L., 66-year-old male, first seen in 2007, had been carried as a type 2 diabetic since 2002. He'd been on a variety of medications, as you see. Home glucose meter graphing, note the very irregular pattern. GTT-IDG study, 2011, showing several elevated insulins, high glucose levels, but no hypoglycemia detected. Dexcom CGM report. Robert L., non-contrast brain MRI showing multiple hypoglycemic infarcts. Patricia F., 76 years old, concerned about her weight, had previously done glucose studies which showed hypoglycemia. This went back as far as the time when she was in her 40s. She had impaired concentration, impaired short-term memory, blurring or double vision, episodes of flushing and diaphoresis, irregular heart rhythm, and trouble with her balance. Patricia F. Medications at first visit included Levemir 30 units, Janumet, Lasix, etc. She had a C-peptide of 3.7, which was elevated, but the eGFR was 53. Home glucose meter report. GTTID, off of insulin, showing elevated insulin values and elevated glucose values. Dexcom CGM report. Computer analysis of Dexcom CGM report. Note that there are no hypoglycemic episodes reported, but the hyperglycemia is recorded. In summary, we have found that Nesidioblastosis is quite common. It is almost as common as type 2 diabetes, but you have to do the basic studies like the 4-hour test for insulin, and now available with glucagon to be able to diagnose this entity. We have seen people transition from Nesidioblastosis to type 2 diabetes. We have used a combination of TZD and DPP-4 inhibitor, and we've managed to reverse the disease in a year and a half of treatment in about 98% of the cases. If a patient is not responding to oral therapy, you should look for an insulinoma or other tumor, solid tumor, which may produce insulin or insulin-like substances. To avoid relapse, we now treat several months past the improvement of the patient clinically and improvement in laboratory testing. Thank you.